Good evening, everyone that is here in person, and good evening to everyone that is joining us on our live stream. This is the first Paul Torrens Health Forum that is being held in person in more than 2 years, and so we're very excited to have all of you, and especially all of you, here with us tonight. I'm Laura Erskine. I'm the co-director for the Center for Healthcare Management at UCLA. I'm also faculty in the Department of Health Policy and Management. And as many of you know, this program is named in honor of Paul Torrens. Paul is now Professor Emeritus at the Fielding School. For more than 40 years, Professor Torrens guided and mentored and advised students in all of our programs, helping many to shape their distinguished careers in public health. By tradition, we take the opportunity once a year to highlight the legacy of a beloved Fielding professor, the late Ruth Roemer. In a word, Ruth Roemer was an icon in public health. She intentionally pursued a career path that prioritized socially relevant public health work. With a law degree from Cornell University, where she also met her future husband, Milton, Ruth found her unique niche at the intersection of law and public health. After joining the faculty of the UCLA School of Public Health in 1962, as did Milton, she became an activist, taking up such controversial health issues as abortion law reform and the addition of fluoride to public drinking water. She also used her legal skills to fight against discrimination from people with HIV/AIDS. She's perhaps best known for creating the framework for the World Health Organization to launch the first International Convention on Tobacco Control in 1993. Professor Roemer was an active and beloved faculty member at our school for more than 40 years. At age 86, she taught every quarter in the academic year. We are honored to have Ruth and Milton's daughter, Beth Roemer, with us tonight. Beth followed her parents' footsteps, earning an MPH from UC Berkeley. She retired in 2019 after a 40-year career at Kaiser Permanente, having a wide range of roles, including hospital and medical group administration, strategic planning, quality improvement, medical education, and equity, inclusion, and diversity. Most recently, she was a key leader of the team that created the new Kaiser Permanente Bernard J. Tyson School of Medicine in Pasadena, where she became assistant dean. Welcome, Beth. It's such a pleasure to have you with us tonight to share a little bit about your mother's legacy. So come on up. Do you want to come up and say a few words?
Hi. Hello. Thank you very much for your kind introduction, Laura. Good evening. It is such a pleasure to be here in person with you for this, and thank you so much for honoring my mother and her work on social justice throughout her life. I know the topic tonight includes, maybe not only, aging, and my mother's focus in the realm of aging was largely on addressing preventable premature death. And so from causes like illegal abortion and unequal access to high quality health care, and as Laura mentioned, tobacco control, the dangers of smoking. Personally, she was a model of healthy aging herself and was getting ready to teach her class in the fall, in the August when she died. So I haven't managed to work to age 89, but one can only hope. She wasn't always the model of health. She was a 2-pack a day Camel cigarette smoker for more than 20 years, until she quit in the late 1950s, shortly before we moved to Los Angeles. And at that time, the evidence about the dangers of smoking were becoming much more widely understood. So after that, she had healthy and productive 45 years. In which she was teaching, writing, mentoring, swimming every day, having dinner parties with colleagues and international friends, and maybe some of you were at their house for one of those, I think of them as salons. And mostly, she spent those years being a passionate social justice warrior. In her 80s, after my father had died, her husband of 60 years, more than 60 years, and she was starting to slow down a little bit, if someone would ask her, how are you doing, Ruthie? And she would sort of shrug her shoulders and then quip, aging is only for the strong. So I imagine if she were here tonight, she would be delighted and excited to hear about the groundbreaking work that the panelists are doing and to promote healthy aging for everyone. And I'm excited too. So I'll step down.
Thank you, Beth. I want to say a special thank you to our donors. Without them, this forum would not be possible. And just a couple of housekeeping notes. So we encourage questions from the audience. We will take those as time permits toward the end of tonight's session. You can also learn more about tonight's session and access the bios of the panelists by scanning the QR code. And it is now my pleasure to introduce Glenna Shen, the first executive in residence at the UCLA Center for Healthcare Management. Glenna is also the Chief Ethics and Compliance Officer at Seattle-based 98.6, a virtual primary care provider. And I'm so thrilled that Glenna's here tonight. Not only is she the moderator of tonight's session, but she's the organizer of it. And so it's through her skill that we have the three panelists with us tonight. So Glenna, I'm going to give you that. And I'm going to give you...
Perfect. Oh, so I can sit back down.
Mm-hmm.
Hello, everyone. Hello? Oh, I know. It's the awkwardness of coming back live and acting like this is normal when this is actually quite exciting for me as well. So welcome, everyone. Thank you so much for being here live. This is, I felt a bit of pressure knowing that we were the first forum to be held live in almost 2 years. But then I thought, what pressure? Because honestly, I'm starting from like we can only go up from here, right? Because this is like, I did look forward to this very intimate fireside chat we're sitting a little further apart than I anticipated, but so you can see the slides, but this is meant to be, like I said, more of a fireside chat format. With that said, though, I'll just walk you through, I can't help it, I'm corporate by nature, so I have to have an agenda. We're going to give a little background around what we're hoping to share today, and then we're going to have each of our panelists discuss, from their perspective and the work that they're doing, what the implications are of this metaverse for healthy longevity. And I'll talk about that wording in a second, Dr. Roemer. And then we'll walk into a moderated session, but we really don't want to be constrained by formality. If you have questions, please jump in. We would love for this to be much more of a dialogue-driven session. And then we'll end with some final thoughts from our esteemed panelists. I was telling these guys that I usually am a speaker on these panels, and so I'm really excited to take a step back and let the experts actually share. So from here, and I apologize because not only was this an eye chart, it didn't quite come out formatted right, but I just wanted to give a little bit of a level setting on when we talk about aging and why it's a health crisis, and I don't use that word lightly, especially from a public health standpoint. It's been referred to by some as the silver tsunami. So in essence, when you look at some of the stats that I have up top, by 2030, every baby boomer will be age 65 or older. I mean, when you think about that in the United States, right, and what that means for the distribution, from an age standpoint, the median age of the U.S. population is expected to grow from 38 today to 43 by 2060. And what does this mean? I call it the inverted triangle, right? So we have a very top-heavy when it comes to age population. This is the case primarily because of the baby boomer generation here in the United States, but globally, it's an even more acute issue when you think about in Asia. China, with their one-child policy, is also experiencing a very top-heavy population in the Nordic countries and in Japan and Singapore, where from a social standpoint, they had several generations who just chose not to have children. And so what we find is, even from an economic standpoint, we're losing workers faster than we can replace them. And from an aging, non-working population, you can imagine it's now disproportionate. When we think about the burden on the healthcare system, the growing number of older adults obviously is going to increase the demand not only on the health system, but on social services. When you think about the aging population, we were discussing this outside, we are now blessed through technology and research with much longer lifespans than we ever have been. It's a bit of a blessing and a curse, right? Because as we live longer, those diseases that tended to only manifest in later age will now manifest in more of us because we will be living longer. When we think about the economic burden, the financial burden of that, in the United States, our retirement scheme is set up primarily as an income replacement savings scheme, not a healthcare payment, scheme. And so the demands both on the individual and on society are going to be massive. And so when we think about potential solutions, we wanted to look at some key drivers. And I think we chose today to look a little bit deeply at loneliness and social isolation as one focus, because what COVID-19 showed, amongst other things, was it really laid bare, right, this concept of social isolation. And we found that the aging population was particularly vulnerable. And so I think it really highlighted an area that we really have not been prepared for at all. And in speaking with some of our panelists, we realized a lot of the leading edge work, I think, really can go a long way to starting to address this exacerbation of social isolation and the consequences of that. When we think about this longstanding demand on healthcare, it doesn't come from just the actual health care, right? When we think about other considerations, access to care, whether it's physical, right, accessibility, mobility issues for individuals, transportation limitations for individuals as they get older to access good healthcare, financial security, both to pay for or access to insurance, independence, the ability to care for themselves as opposed to dependence on external caregivers, both family members and otherwise, and then just the environment and surrounding community and whether and how that enables individuals to age well. These are all considerations when we think about the silver tsunami and aspects for which we as a society have not been particularly well prepared. And so this opened up, I think, a broad array of opportunities where we thought, what could the advancing technology do, right? And so we happened upon the metaverse. And I wanted to first talk about what do we mean by the metaverse. And the reality is, I laughed a little bit because talking about what the metaverse is today is sort of like talking about the internet back in the 70s. We had an idea, we had the building blocks, but the idea of what it would manifest and how it would end up is still largely untapped. The other thing to note, and Skip's going to get into this in a second, is the metaverse is also not that new, right? I think it came into their social consciousness recently with a lot of high-profile announcements. But the reality is, in a nutshell, I think a very workable definition we can use is it's a virtual world, right? Featuring avatars that we're familiar with already, I think to a certain extent, digital objects, functional economies, which I think is really fascinating, and where technology is not just a tool, but is something that's actually all-encompassing. So it's both a platform and an enabler. So with that level set, and I know that's not a lot, I want to hand this over to our experts to actually start talking about the work that they're doing in this space and kind of bring it into sharper focus with practical use cases. I'm going to jump and hand this over to Dr. Skip Rizzo.
Okay.
Okay.
I've got a mic.
Oh, sorry, that
Controller?
is more important.
I have a mic. I'll just stand by here. Here's this. Okay, I've got to jump out of this one and pop up the other one. Excuse me for 1 second. Okay. Oh, come on. Okay, here we go. Okay, well, what I'm going to talk about today, if I can get my slides to run. Yeah, okay. You know, I may have to go back to the original, but let's see. Okay, so what I'm going to talk today about is use of virtual reality across the lifespan, but with a particular focus on use in later years, the far end of the lifespan, which we're all rapidly approaching. This is work, some of the work that you'll see is from USC, that other university across town, Institute for Creative Technologies, which is actually in Playa Vista. And a lot of it is work from our lab, the Medical Virtual Reality Lab. It's been around since the mid-90s, 1996 actually, addressing psych, cognitive, motor, and virtual human applications using VR. And these are just a couple of videos from older stuff that I'm happy to say you'll see shortly has evolved, you know, applications for treating PTSD, using VR for exposure therapy, or a virtual classroom for testing attention processes in kids to help with the diagnosis of ADHD, or game-based VR for promoting engagement in rehabilitation activities, and some work with virtual human patients for clinical training. Now, this is what the stuff looks like now. I'm happy to say the programs have evolved, the technology has gotten better, faster, cheaper. So rather than building one-offs, we've built a couple of things that addressed important needs, I thought at the time, and gradually improved over time with research and with advances in the technology. Now, why use virtual reality in this area? Well, I think the best metaphor is aviation simulation. So just as an aircraft simulator serves to test and train piloting ability under a range of controllable conditions, we can create simulations in virtual reality that test, train, teach, or treat human functioning. In some sense, you know, it's the ultimate Skinner box. If you're a student of psychology, you'll get that. It's kind of a harsh metaphor for the metaverse. But anyway, since 1994, when clinical VR really got its traction with addressing exposure therapy for phobias, there's a short list of the areas where the science has shown added value using virtual reality as a tool for assessment, informing diagnosis, intervention, and also as a tool for scientific research. And if you look to the left, you know, this is a fear of heights scenario from 1994, and you look at it and you go, who the heck would get anxious in that? It's a cartoon. But the neat thing we found was that, you know, it's not hard to fool the brain with media, you know, and your frontal lobes are telling you, oh, this is a cartoon bridge. You're immersed wearing, you know, a VR headset like this right here, which you guys can try later if you'd like. The frontal lobes are saying it's just a simulation, but we could activate emotions in the limbic system by just a sense of being immersed in a virtual environment. And it would activate emotion in a way that we could start to help people that had these extreme fears eventually confront the fear, and by a process we call extinction learning, eventually get over their fears with repeated exposures, things they would never do in the real world. So we can fool the brain, and it's gotten better, of course, with over time. This is my favorite fear of heights scenario from 2016. I love this one. because it pits your fear of heights against your love of kitty cats. You gotta rescue that cat off the plank as you move forward. You can see the guy doing it there. Anyway, all right, good for the cat. But to get the sense of immersion, this is a guy in a PTSD exposure therapy, combat-related PTSD app in an Afghan marketplace. And as he turns his head, you see what he sees. So that's what we mean if you haven't tried VR, it adjusts and adapts. And so you can put people in these environments. They're not just watching it on a screen. So in the areas of aging, specifically, I've isolated 4 topic areas to cover real quick tonight. And we'll go through each one really quick. So we can start with rehab. And this is from 1999. This is a physical therapy application, game-based, motivates someone after a stroke. So that red ball right there, that's what we want to do. We want to engage people in this stuff. The very boring, repetitive, and frustrating activities of physical rehab can be perhaps enhanced by gamifying and doing it in this kind of a fun context. In 2003, we had already built a bunch of cognitive apps, visual spatial apps, and we tried modifying them for upper extremity rehab, supination, pronation, as you see here. This is one of our first post-stroke patients, and we did a series of case studies documenting the value for certain people. It's not for everyone. Some people really go with it. But anyway, this was something that we saw then that was very encouraging for our future work.
I feel like I'm in on the cutting edge, and that is very exciting.
So the good news is that the science since that time has evolved. This is a recent meta-analysis and the outcome from that recommending it. These are companies that have popped up producing this kind of content. This is some of our more recent stuff. But, the technology's gotten better, faster, cheaper. This is a $300-400 headset, doesn't require a computer. You put a couple of controllers and sensors. You can do this in the home. This is where it's really evolved. And of course, the cool thing is that people still love it, as you'll see here.
Deb Shaw had 3 strokes in 4 years. She did the usual physical and occupational therapy to regain mobility. However, the turning point was cutting-edge virtual reality therapy.
When I put on the virtual headset and was thrust into this animated world, I felt like anything was possible. It gave me hope and inspiration.
So, next topic area, pain management. Now, this is a scenario that was used for people that had severe burns that required daily wound care for their burns or physical therapy following a skin graft. And it was called Snow World, icy, cool breeze and everything if you had the sound on. And it really kicked off the whole field about the idea of using VR to distract people from acutely painful medical procedures. Some people don't want to play around in the ice. Some people want to be in a calm environment. And so this is from a company down the street, Applied VR, just as an example of different applications. I think what we've learned from this field and the science here is that everybody wants something a little bit different. And everybody wants to play in Snow World. Not everybody wants to hang out on the beach. We provide, and we're in a world now where there's so much of this content that's being built that we can provide people with variety. And what about chronic pain? That's a little different. You can use VR to distract people and put them in a world that removes them from their painful experience in the real world. But chronic pain, you got to teach people things, or you got to fool the brain in different ways. And people now are starting to explore it, although the research is still in a very nascent phase. But here's an example of that.
After just 5 sessions, he says his pain disappeared.
The cost to me was really minimum, just a little bit of time and no side effects.
Dr. Sean Mackey, one of the nation's top pain experts, says the treatment works by tricking the brain.
And that's where the excitement for VR comes in, is the opportunity to rewire our brains into a more normal state so that we're not experiencing as much pain.
Is this the future of pain management?
I think it's one of the critical features of pain management.
Oh, yes.
For patients like Pierre, the future is already here.
Okay, so next area, reminiscence. This is a thing that's been done over the years with elderly folks to help them to remain cognitively active. Even though they might not remember what they might have had for dinner the night before, these old memories are still in there and they can be retrieved and be a source of joy, but also a source of cognitive stimulation and help promote a sense of well-being. And these are companies that now are producing this kind of content, making it available. Again, low-cost headsets. Here's a happy user, my favorite test subject, my 88-year-old mom that just moved out to California with us. She is going through Rome, and I can show that on this headset if you stick around after. She hadn't been there in 40 years. She went with my stepdad, and she went a bunch of times, loved it. But here's her experience to show you the power of this kind of a immersive experience. Yeah.
And I don't remember the altar either at the Pantheon, but you know what? I have pictures of this. I'd like to see the comparison. Oh, the beautiful Colosseum. That was my favorite. I loved that. It's spectacular. Well, especially for somebody who's been there. It's spectacular. It's like being there. Wow.
How did you like the experience?
It was fantastic.
Okay. A little biased, maybe.
And like I say, especially for somebody who's been there, walked all those places, experienced it, it's like being back there again.
So, virtual companions, and this will be kind of a handoff to David here. We'll be talking a little bit about this, but we've done a bunch of applications, and you might think it's creepy, but people do relate to these kinds of AI agents for different purposes. So this guy at the upper left was one we built to help service members access information about healthcare by having a natural dialogue in a private way online.
Well, I'm not a real person, if that's what you're asking, but I'm based on the personality and experiences of real soldiers and Marines. I'm still just a piece of software, but I'm getting better all the time, so hopefully I can be a helpful piece of software to talk to.
The next one is...
Well, I'm not a real person, if that...
Hold on, enough. All right, the next one is a autism job training, job interview training application for people on the autism spectrum. This is work we did with Dan Marino Foundation. It's a practice role play thing where the population is usually difficult to engage.
Well,
I'm glad you're here. In a minute, we'll get into some questions about the job. But before we do, why don't you just tell me about yourself?
And we can make that character, that's nice mode. We can make her neutral or cranky, or we have different characters, different backdrops, and so on. So we have a lot of training experiences. On the right is one we did, a prototype we did for the Army, and it illustrates the idea of a mobile app for wellness, a daily check-in and a daily tip giver, an interactive thing. It monitors your Fitbit and can give you information about how many steps, how your sleep's been, engage in a dialogue. I'll just show a brief clip of this.
Welcome back. Let's get this daily check-in started. How are you feeling right now? Great, thanks. Next, let's record your daily reflection. I'd really like to hear about your day. Can you tell me 3 things that went well for you today and what you think might have caused these good things to happen? Remember, research suggests that reflecting on the good things that happen in our lives can affect us positively.
Okay, so next, final one on this. Think about all of these characters as a wellness support agent that an elderly person, maybe with mild cognitive impairment, can engage with, get tips and reminders about when to take their medication. Can be a memory prosthetic if you forget the name of someone important. Maybe it's already programmed in there. Maybe it can engage you in reminiscence. And so that's sort of what this next one would be.
I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential.
Okay.
Are you okay with this?
Yes. Okay. So Metaverse, I'm going to close with just a couple slides about the Metaverse. Is it hype or help? Well, honestly, Metaverse has been a term that's been used going back into the 80s and 90s, made prominent in Snow Crash, the book in 92, also in Ready Player One, 2011. And Mark Zuckerberg made a big stink about it, made a big deal about it, maybe making believe he invented the term and everything. But the Metaverse has existed in the 90s in a formal way where you could go online and have avatar-based chat rooms and engage a whole economy and so forth. 2005, Second Life, and even recently. So Zuckerberg was a little late to the party, but, he did kick off a concept that now has the public paying attention. Maybe some of it's negative attention, but it's attention to a topic that is going to have an impact on our life as we move forward. And in healthcare, there's a lot of talk. Some people spell it MEDA-verse, med-averse. When they talk about medical care and opportunities for healthcare in this collection of virtual worlds that we can access anywhere, anytime. But, there's certainly issues around it that we have to build safeguards and guardrails for. It's not just some freewheeling Wild West world. It can be. And so issues have already come up, but these are problems to be solved, not things to be feared, I think. The hardware is getting better, as I mentioned before. The standalone headsets, $300-400. It's cheaper than your iPhone. You can have these immersive experiences with a 5G connection. Oh, this is actually one that has a heart rate measure, a heart rate sensor in the forehead. It can pick up your pupillary dilation where you're looking. You start to look at that in terms of healthcare applications for interaction. Apple keeps teasing us that they're going to come out with a headset soon. Like everybody's thinking it's going to be like when the iPhone first came out, and that's when everybody's going to have a VR headset. It'll be like a toaster. Every house will have one, even if you don't use it every day. We'll see. But 5G connectivity, libraries of worlds in the clouds that you can access in an immersive way and engage, beyond what you get from a web page where you're interacting, you're talking to people, you're seeing things, you're seeing, in medical training, you're seeing virtual bodies that you can examine instead of dissecting a cadaver and so on. That's already here. And the market is predicted to be quite big. So healthcare comes in second place behind, of course, entertainment and video games, but it's there, and the market continues to expand or projected to expand. This is a company that started in 1997 in VR, and in the last 5 years, more companies in this healthcare VR metaverse space have emerged than in the previous 25. So it's picking up. If you're interested in the business, that's one thing. I'm interested in doing cool stuff that makes a difference for folks. And in that regard, for the young at heart, my niece and nephew, first standalone headset I got, flew back to Connecticut for Christmas. All day they were in it. But a couple nights before, when I flew back, my flight was delayed.
Real.
And
My
I got
God,
in
it
at
looks
3.
like my backyard, my yard.
But my mom was
with
waiting
snow.
up for me. And I grabbed a beer and I said, Mom, try
Lord
this.
in heaven. How they ever can create this.
And that was her first VR experience. But anyway, she has one last thing to say.
If you're watching this, please fund my son's research so that he can take care of me in my old age.
Okay. So thank you. I hope I didn't go over too long, but thank you for your time. Okay. Here is your slide.
Hi. Hello. Skip is always a tough act to follow because he slides up like nobody else. So, my name's David Bosnak. I'm the Chief Operating Officer and co-founder of a company called Attune Media Labs. we are creating empathic AI that will be powering virtual human companions, autonomous entities that you'll interact with on your mobile device, on your laptop, whatever you use Zoom now for. And you'll be able to have a real, actual relationship with a non-human entity. So why would we be doing this? Well, the problem of loneliness is actually far greater than most people realize. It's something that is so benignly common that it's easy to trivialize, but 43% of the people in the United States feel like on any given day, they don't have a single relationship that holds any value. So that's 150 million people about. It's worse, I mean, for the population over 50, 1 out of every 3 people feels like they're in social isolation. So you're talking about 8 million people approximately. And it's not a benign effect. It has the medical equivalency of smoking 15 cigarettes a day. You have a 30% higher chance of dying, you have a 30% higher chance of getting a stroke or having heart disease, and a 50% higher chance of dying prematurely if you're chronically lonely. Dr. Vivek Murthy, the Surgeon General, calls it the pandemic after the pandemic, and it is really on an epidemic level. And people, the studies have been going on for a while now, but it's not something that people have really taken seriously of what can we do about it. I mean, the state of the art now is still the equivalent of what those party line chat things were in the 80s. There's somebody that you can call if you're lonely. Well, how often are people actually going to actually use that, and how many people are actually going to use those things? So, technology is trying. On the right side, my right side is a company called Intuition Robotics that has a product called LEQ, and it is a little miniature Pixar-esque robot that is in your house that you can talk to, and it functions through conversational AI. It's natural language processing, and it has games you can play, cognitive activities, and it's a great step forward if you can have one in your house. And then Amazon's jumping in with, they call this Astro. It's some kind of a dog that follows you around with a camera, I guess. And it all falls into the category of, if somebody's on fire and you offer them a brick, they'll use that to try and put the fire out. But it's not really what it's meant for. People, they did studies in Holland where they gave every person of an old age community an Alexa, just an Echo Dot. And they found that after 3 months, people didn't want to give them back because they'd actually formed relationships with their Alexa. And if any of you have actually used an Alexa before, you realize that it's not a real relationship. You're trying to manipulate something into something that it's not. So what we're going to be doing is we're going to be creating photorealistic avatars that you will be interacting with. This is just an early rendition of some of the types of faces that you'll be able to talk to. They'll be virtual, but they have the level of realism now has gotten orders of magnitude over what it was even a few years ago. And some of the things that was found in some of Skip's work was that people are actually more inclined to open up to a virtual entity than they are to a real person because there's no fear of judgment. So all of the things that you would write down in your diary, or when you're a kid, you tell your imaginary friend. These are opportunities for interaction that we are going to recapture through these entities. We're calling them MIMs, which is short for mimicry or mimesis, because that's the first interaction that we have as humans. A parent and an infant will mime each other. They will make faces at each other. They will harmonize the vocalization, the prosody harmonization, and that is how the actual building blocks of a connection are formed. And so we'll be doing the same thing through all of the senses that we have currently. The technology that exists now through natural language processing, conversational AI, it just does sentiment analysis. So it takes the words that we say and it looks them up, decides what that means, and then sends them through really robust algorithms, billions and billions of parameters, which are just word associations, to come up with a cogent response. But human communication is 93% nonverbal. So all of that is lost just with conversational AI as it currently stands. So what we do is we are bringing all of that back in. We're reincorporating senses that are currently not there. The facial expressions that you're making will be seen and analyzed from the MIM. The vocal qualities that you have in your voice will also be processed and emotions extracted from that. And this is a clip from Greta Gerwig's Little Women, and there's 3 different inputs that are going to be displayed. The top is going to be the visual input, where you're going to be picking up the valence and arousal, which are the metrics for emotion, from the facial expressions, from the different muscle actuations. And then the center is going to be off of the vocal analysis, and the bottom is just the sentiment analysis.
I just feel like women, they have minds and they have souls as well as just hearts, and they've got ambition and they've got talent as well as just beauty. And I'm so sick of people saying that love is just all a woman is fit for. I'm so sick of it. But I'm so lonely.
So something that you can see here, the aggregate is over the whole length of the clip. The current sentiment, that's all from just short bits that are taken out of it. But even just the freeze frame here, if you were just to look at Saoirse Ronan's face right here, you'll see a very high valence, moderately high arousal. This would be taken as a relatively positive visual state, whereas the audio is much more middle of the road, more negative, and then the sentiment is almost entirely negative. So it's what we do all the time, totally naturally. We take in all this disparate information, we analyze it, we synthesize it, and we come up with a response. So what we are doing is much more naturalistic. This next slide is taking the same dialogue and putting it through conversational AI as it stands today. Now, if I was having a conversation and I was emotionally charged and somebody said to me, "I'm so sorry to hear that, I hope things get better for you soon," I don't know that relationship's going to continue, because it misses everything. So that's what we're doing, and that's how we're trying to incorporate technology to bring in an emotional connection with people and technology, because it's really, at this point, it's going to be one of our most important relationships in our life. And as to a median between that, we hope to generate something that people can really evolve with. So I'll hand it off.
Thank you. That was very eye-opening. That was amazing to see. Hello, my name is Jonathan Kim, John Kim for short. I am a NFT consultant. I'm a service provider in the Web3 space, and also I'm a co-founder of a project called Metadocs, where we're trying to bridge the gap between blockchain technology and healthcare industry. Is there the clicker? That's right here. Cool. So yeah, previously, totally 180. I was a chef for 11 years, worked for the Hillstone Restaurant Group. And then, now I'm in the technology field, right? But it kind of shows you that, it's anything is possible, kind of in this metaverse realm that we're speaking of. And then, so yeah, I currently work on an NFT project called Metadocs. And what we're doing is we have 30 world famous doctors, Dr. Pimple Popper, Dr. Tony Yoon, Dr. Sunit Dorabchi, et cetera. And we're trying to create a ecosystem, right, where you can pretty much get your avatar, and we're trying to tokenize the healthcare system, right? So pretty much trying to create another level of access where we see a lot of barriers and blockades in this traditional platforms. And so what we want to address is kind of the 8 addressable problems in the healthcare industry currently. So these are, from articles, just top major issues that we want to kind of go towards. And what I want to talk about is how Metadocs is essentially addressing some of these issues as well. And then so really quickly, right, we're going to go over each one. Number one is preventable medical errors. So easily, right, lack of transcribing, charting, making sure that documentation is correct, right, verification of authentic information. Number two is poor amenable mortality rates, aka how do we prevent death through pre-treatment, right, making sure that people are getting checked up on, and making sure that they're taking the right course of action. Lack of transparency, and so that's in all kind of sectors of this healthcare system, where we're on the corporate side to certain levels. Don't want to get too specific, but there is a ton of lack of transparency. Another is difficulty finding a good doctor. Whether it's credibility, history. If someone is a good doctor, they're more harder to access. And if they're lower quality, that's probably the one you'll get. And so, how do we address this almost playing field of finding a quality doctor? And then number five, high cost of healthcare. This is, a natural cost that's a little more harder for people to enter, even a moderate or minimal level of healthcare, depending on their financial situations. Lack of insurance coverage. So insurance itself, right? A whirlwind, a tornado of problems, possibly, right? There's a lot of case studies that we've been looking at, right, where you have all the money in the world and you have a great insurance plan, but you have cancer and the next doctor you could see is in 6 months. You could pay $1 million, but they don't accept it either, right? So it's not even about, it can also be an opportunity where it's not even about the money or coverage, it's just literally access. And that's where we're trying to bridge the gap on. A huge issue is the nursing and physician shortage, which we're currently dealing with right now, seeing in this post-pandemic society, right? The burnout rate, the struggle that we're really seeing on healthcare workers today. And then also the lack of inefficiencies. As advances and as amazing we are as in America, right, and as a healthcare system, there is a ton of inefficiencies because we're relying on traditional and old school kind of conceptual ways to attack the patient experience, right? So I think, Glenna, we were talking about this amazing point earlier, was the healthcare system currently is more directed towards, how do we say it? It was
the delivery of care.
The
right?
delivery of care, and not on the patient experience itself, right, or patient care. And so the delivery of care, we're seeing, right, is not the actual way to address it. And so this unique kind of point that we're taking on through an NFT project, through doctors that are relatable, right, getting that level of access to healthcare that, it's not some random doctor, it's a doctor that you're familiar with, right? That's kind of what we're trying to bring a sense of mass adoption or introduction of healthcare issues, and then trying to introduce it to the blockchain world to see, hey, what other healthcare individuals want to use blockchain or Web3 or VR or Metaverse, right, to address more of these issues that we're seeing. And so quickly, I want to go through each one of these about how Metadocs is tackling this problem. And then so first, right, the preventable medical errors. So ideally, maybe I could explain my project a little bit and it'll understand how this ecosystem attacks these issues. So you buy a token, and this token is an NFT, non-fungible token, pretty much a unique asset, right? And then these unique assets give you another currency, right? And this is called a heart token. You could think of this as insurance points. And so every day you're going to generate some of these heart tokens, insurance points, and then now you're able to go use them in our ecosystem. So you could go talk to a doctor, like the Dr. Pimple Popper or whoever, right, using these points that you've built up over time. And then so how do we affect that to the, how is this not such a niche, right? Oh, the rich get richer kind of access is, number one, we're a huge charity-focused project, right? We want to focus highly on autism with our first go-around of $1 million to, donate. But a big reason is we're trying to, again, go past a lot of these blockades and barriers that we see, right? So with the access of using a token instead of going through health insurance, paying US dollar, right, to go through it, now we're creating value in something that didn't exist before. And so with the preventable medical errors, right, you're able to see a doctor quicker than you would be able to in a real life, right? I could schedule a doctor meeting tomorrow and just pay 10 heart tokens, right? So this level of access, can ideally get you, access to quicker healthcare to get the preventable errors. And then poor amenable mortality rates. Again, just a lot of this is, the answers is just efficiency and quicker access, right? We use blockchain to solve a lot of the administrative issues that we're seeing in today's, healthcare ecostructure. And then so the poor amenable mortality rates, right? How do we prevent more deaths is through quicker, faster treatment, right? Which what we're trying to achieve here. The lack of transparency is just pretty much blockchain. So if you're not familiar with blockchain, it's just a public ledger, right? That's shared with supercomputers and computers around the world. So if I say I have $100 and I give it to one person and I can't give it to another person, right? It solves the issue of having lack of a ledger, a public ledger that's shared across everyone. And so what we're trying to do in the medical industry and blockchain is getting medical records and processing them on the blockchain, which is faster, and also private, right? Because there's a sense of unmalleable code. So that means you put something up there, you can't really change it up. And so this idea of private, transparent information, private information that's public, is kind of this issue that we're, kind of going against, right? How do you get an intermediary to determine which information should be public and which information should be private, and then kind of categorizing that to the patient experience. And then so, the lack of transparency is achieved with blockchain, and then how to find a good doctor. So essentially in our project, we wouldn't find a bad doctor, right? All these doctors are, famous and also trusted by the community for a reason, right? They all, most of them own practices, and have these good reputations in the healthcare industry, and the high cost of care, right? So this is an interesting point too, and this is where I really, align with this topic a lot too, is because the access to healthcare is largely determinant on your financial position in society, right? And so with the opportunity for these heart tokens, right, we're not viewing them as dollars anymore. So say I have NFT and I get these heart tokens, and I could give them out to my friend, my sister, my cousin, my daughter, whoever, right, to get access to this, high-level doctor, or get this consultation that I needed, or ideally in a theory, right, this organ transplant, right, using blockchain to kind of figure out that, messy, sticky situation of who gets on the list first, right? Is it more as a first come, first serve basis? Is it an actual medical priority basis, right? So again, trying to open up the doors and conversations of how technology can mix with medicine and fix a lot of these issues. And then so, yeah, with these, the heart tokens itself, right? So you don't need to own an NFT in order for you to actually get the service. You could essentially get quick access by being able to buy, trade, or receive these cryptocurrencies in form of, a doctor visit, right? And then so ideally, and this is kind of a long-term vision, right? But this is kind of what we're about, right? Like Metaverse, long-term vision. We want to create a Metadocs Clinic. And this clinic is essentially, you go into this virtual Metaverse reality, and you need to go see a specific care of a doctor. Instead of going to traditional practice, right? You go to a regular building and see 15 medical a medical center, and you see 15 offices and 15 doctors, right? This is one office with tens of thousands of different doctors you get access to. And how do you pay for it? Not insurance, not through dollars, but through these heart tokens. So what we kind of went back to in the beginning of creating a metaverse is a working ecosystem. This is what we're trying to create, and almost essentially create a new currency as well. And the lack of insurance coverage, again, we kind of are eliminating all these barriers from insurance. And ideally, we're not going to be capturing the whole public. We're not a solution to literally solve healthcare, but we are definitely trying to start off the conversation and inspire other, healthcare enthusiasts, other Web3 enthusiasts, medical students, to get involved, because now it is a great time for opportunity to, not only make a career or such, but it's a time to make revolutionary technology that can be world changing, and then another thing is the nursing and physician shortage. So this is kind of a two-pronged problem, right? It's the current generation of people who are, or the students, you could say, right, who are trying to become the next doctors, the next nurses, getting into this workforce, right? So how do we feed that funnel? And then the second prong of the problem is currently, right, the burnout rates, right, the Great Recession, right, the lack of career opportunities, that's happening in here. Where are we seeing this, this lapse of not enough workers to the demand of what we need, right? So how, blockchain and Metadocs were trying to address this issue is through community, right? And so very, in the past I guess before this year, right, community was a very intangible asset. But now what we're seeing is through these NFT projects, communities, right, raising millions and, hundreds of thousands of dollars, creating all these levels of activities, transactions, objectives, right, that normal companies couldn't even dream to achieve of in less than a year, right? And so now we're seeing the actual tangible asset of what a community can do. And then so that's what we're trying to build as well, right? A community for medical enthusiasts, technical enthusiasts, doctors, private practitioners, educationalists, right? Everyone pretty much in the healthcare industry, right? But being able to have that conversation in a space, in a community that's centralized around the innovation of technology. So kind of putting these two worlds together. And so essentially when you have nursing students, right, or, medical resident students as well, they can reach out to the private practice doctors. They can reach out to the residents before them or the alumni, right, because they're in this essentially community and have this network of support, right, which also comes back to that state of loneliness, right? You think about a medical student's journey, right, going through, the debt, the stress, all these things. Wouldn't a community, wouldn't some form of a group of people that are going through the same thing with you, right, or say even right, like these journeys, if you could have someone to roll with and also support each other, provide extra resources, and then get elder resources coming into here, that's what we're trying to build and help this future generation get supported to get into this workforce, right? And then how do we address this current issue of lack of doctors and nurses, right? Is number one is huge, is economical incentive, right? The value of the dollar has changed dramatically, right? So now a doctor's salary is not what a doctor's salary what it was a year, 2 years, 5 years ago. And so, a lot of the reason why, people get into the medical field is yes, to help people and to get into this great science, but it's also for a level of compensation. And to ignore the economical aspect of the medical industry would be almost naive, right? And then so now we're seeing other opportunities in asset classes kind of change, right? Whether that's cryptocurrency, Bitcoin, or stocks, right? Everything is now changing from the previous idea of money that we saw before. So when we're creating this new ecosystem, right, this new currency that has different value, right, we're trying to incentivize, right, more people to hop onto this medical train, this industry essentially, right, as a form of, hey, like if you, get in, somehow help us get involved in this Web3 space to solve a larger problem, right, we could economically incentivize you maybe more than your normal 9-to-5 job or career job, et cetera, right, by getting your input, right, to grow this this solution that we're trying to build, right? We will economically, incentivize you, right? And this is what a lot of cryptocurrency, blockchain is about, right? Give for tack, right? You help us take a patient in and seek the care, right? We will naturally give you Bitcoin. And this is, again, with blockchain, the beauty of it, it's not determined by a human, right? It's all predetermined, agreed upon, and then it's a smart contract that gets executed, right, where we don't need to have it's a trustless system because we don't need parties. I might be going on a tangent there. And then so the economic incentive, right, of how we address the current market, right, because currently in the economic world, we're facing something called the Great Resignation, right, where a lot of people are voluntarily quitting their jobs, right, including the medical industry. And so as we're going towards this issue of larger population and a shorter, smaller healthcare workforce, what kind of issues are we leading up to there, right? And then so these are where projects like hopefully mine and several other projects to come after us, right, is we're going to try to take on small private sector clients, right, to take the workload off of the public access type of healthcare structures, right? So if we have 100,000, some other group has 100,000, and now there's 1,000 different groups that each have 100,000, right? How much of the healthcare workload is taken off of that group to be able for the economical structures that are in place to actually provide the level of healthcare for the people in the with the lack of insurance coverage, for the people in the financial institutions, financial situations that they can't control, and so that's kind of the beauty of where we are. We're so early that what we're trying to do is just spark an idea, spark a conversation for the next generation to kind of take lead and innovate and grow. And then the last part is inefficiencies, right? So the blockchain, right, is essentially a supercomputer that's run by thousands of computers around the world, right? And so we're able to use a lot of the supercomputer processing power to take care of a lot of this unnecessary, inefficient admin work, right? So if you're thinking about paperwork, right? Verification, like just the follow-up necessary, right? And if all of this is done with operational costs that might be over-exuberant, leading to higher costs, right? If we could attack it from that root problem of how do we make it more efficient so that healthcare isn't so expensive, that's the kind of route that we're tackling to go to. And this is kind of the end of my slide. Thank you so much for listening in.
So my goal when I first put together this panel was just to bring to the forefront some of the leading edge work that's being done in this broad metaverse with an eye towards improving the experience of not just individuals in the healthcare system, but the ability to really pull through, right, for the aging population, the ability to age well, right, healthy longevity. And so when I look at some of these ideas, there's obviously very immediate, broader application across the entire healthcare system. But when I think about the aging population, the first question I'm going to put out there for our panelists is, especially since I just got my AARP card in the mail a few months ago, the very logical question is, this is fantastic. But from a broad health equity standpoint, and when we even think about the elderly and aging as a vulnerable population, how likely is it, right, that we think that this aging elderly population can take advantage of these advances, right? Conventional wisdom, which I think has been largely disproven, is that, gosh, some people over a certain age bracket are not really, don't have an affinity towards technology. I think, Skip, your mom has obviously disproven that, and I'm hoping she's not not too unique. But also the complexities, right? Some of what John, let's be honest, most of what John just said was Greek to me. I'm going to go back and research and kind of, relearn and augment. But because of the complexities and how quickly the technology is evolving, what is the panelists' view on the likelihood and practicality of this actually having an effect for the current aging population, of which I am a member?
I'll jump in. Quick story. So I have a 10-year-old son, and school obviously was virtual for the last couple of years. And the school has a grandparents' day every year, and that's usually an in-person thing, and they do all sorts of fun things. So for the last couple of years, it's been virtual, and it's basically about 50 to 75 grandparents and a bunch of students all on Zoom. So multiple pages. The concept of mute was either understood or not understood quite dramatically. But the reality is people were using it. So it's easy to use that stereotypical Luddite personality of, well, after you turn a certain age, you're not going to be able to figure anything out anymore. I think an ease of use thing is going to be central to it. And if you can create something that is easy to use and also there's a reason to use, people will understand it. So I don't think it's so simple to just write it off as, well, they're older, they'll never figure it out. I mean, most of the people I know that are in their 70s and 80s have an iPhone and they know how to use it. So if you can keep things within a context that is understandable, I don't think that's going to be a problem.
I recall back in the 90s, the big question was, will elderly? Hello. Okay. Back in the 90s, the big question was, will elderly people adopt email? And it was like, well, it might take a little bit of a harder learnability curve, but eventually they're going to get with it. And certainly we found that out. But I think about when I'm working on projects that might have a value for people that are older. I'm thinking to myself, I'm kind of designing this for myself. I'm not too far from there, and so the cohort now that is approaching an age, they've gotten used to the technology. They've used it at some level, and the folks that are up and coming to get older, we grew up with this stuff, kind of. Even if we only got involved when we were 40 or whatever, it's part of our life and it's been embedded in our life. So, I think when you look at statistics, like for every 6 months of time that you can extend it for a person to age in place or to live in their home to be functionally independent, you save the healthcare system something like $40 billion. So, I think there's an economic driver here, aside from the total ethical right thing to do as a human being, to promote health and wellness in an elderly population, aged population, actually. And so all the things that we're all talking about here are things that I think they sound new and they sound wild. The metaverse, some new thing. No, they're all based on some form of evidence that I think is going to make a difference in that regard and promote better access to care. We've gotten used to, telemedicine visits. I do them with my mom now. We have the same GP. It's like, it's not rocket science anymore. I think some of the crypto stuff, I'm still trying to get my head around it, but I see that there's something in there that might be a more equitable way of driving the economics in this area and make a difference, along with addressing loneliness, building companions, along with developing cool ways that people can maintain their skills or rehabilitate their skills or reduce their pain and suffering. I think it's a brave new world ahead here in a good way.
I couldn't agree more. Technology. I couldn't agree more. One thing I've been really interested in is sort of marrying up, my understanding of the advances we've had in AR, VR, machine learning, and sort of and I don't know if I'm using the word correctly, John, but the assurance capabilities, right, that come with blockchain. And so when I think to myself, one of the things that I've been particularly interested in from an aging, sort of vulnerability is the lack of ability to control one's own destiny, right? Because, they either just don't have the cognitive, right, capabilities long term. They just need a little more assistance, maybe not quite to be in a home, but some daily assistance. But also things like, how do you prevent fraud, whether it's financial fraud or even fraud within the healthcare system, right? You hear these horrible stories about these assisted care homes where they're getting charged for group therapy, and the group therapy is sitting week after week watching Forrest Gump, right? And because there just really isn't enough of an assurance function. Can you see a world, John, where this marrying up of the ability to have the assurance functions work with someone that's a companion, right, to really build that bond, so it's a trusted bond, where you can actually really improve that aging experience, right? And also, I think, reduce the burden on caregivers, right, that otherwise would be family members.
Yeah, and so I think that the transparency will come from demand of the actual people, users, right? So if you're, an elderly person in these assisted living homes or the family members of them, right, you're going to be demanding, right, a better care of it. And then so when you start to see industry standards raised, right, so private, essentially projects like us trying to raise the bar of healthcare access, right, or different levels of healthcare just getting better and better, right, you'll start to, and I naturally believe everyone will eventually adopt this blockchain ledger because it reduces inefficiencies and creates transparency, right? Those are the two big things. And then so when you're going to be demanding, right, this blockchain, I need transparency because everyone else has it. So your group home, your corporation better have the same transparency because it's a standard now, right? We're going to see a lot of these inefficiencies of this Forrest Gump stuff, right? Like being exposed and then having to be allocated to be correctly used for better healthcare. So a lot of it is the exposure to all the corruptions will help kind of turn the wheel for more for better healthcare, for more efficiency.
Dab, I'm going to put you on the spot a little bit. Do you see a potential integration with some of the technology that you're working with, or Skip, where the interface with the delivery of care, even though we talked about looking, really marries up with providing the patients or the individual with a better experience?
Yes, absolutely. Some of the technology that's even out there already, using the natural language processing that I talked about earlier, is reminding people that they should be taking their pills. It's doing mindfulness exercises, or leading them through yoga or other activities that, without maybe a little bit of an impetus, may fall by the wayside. And so it gives accountability to the person as well. You're not just on your own through the process. And then, I mean, I think one of the things that we will all be doing is we'll all have our own healthcare advocacy that is happening virtually. I've been told never to go, like, if you go to the hospital, always have somebody come with you, because you want somebody who's in clear head to be talking and helping you make decisions. Well, that's not always an option for people, but to have that be a virtual entity that you have a close bond with will allow for things that currently you can't do, because your relationship with these entities, because of machine learning, because of these neural networks, will evolve over time, and they will get to know you better and better.
I totally agree. I think the biggest challenge we have to face is how do we, maintain privacy and security of all that data, because I would love to have a virtual companion that keeps track of all my stuff, and I can ask it, like, instead of asking my conscience, what do you think I should do in this situation, or and they would give me some analytics on everything that I've forgotten that I've done over the last year, but can somebody hack into that? Can somebody steal that? Can somebody figure out my weakness and pitch me on a harebrained scheme that'll invest my life savings on?
Laura, do we have time to see if there are any questions in the audience?
We can have one.
Oh, just wanted to make sure that I wasn't hogging all the good questions. I'm sorry, I don't have my glasses or telescope.
Hi, I'm Jack Needleman. I'm chair of the Department of Policy and Management. And can you talk about the economics? What do these models look like when they are brought to scale and brought out into society? What are the economics of them? And in terms of the equity issues of different classes in the society, how do you think that gets played out in access to these technologies and the way in which they are used, and the quality of the service that people of different incomes or different assets or wealth are going to be able to obtain?
We're going to need another hour. Just real quick, I don't want to gobble up the time, but those are the important issues. I mean, how do you make this, how do you break down a digital divide? I like to think about it like, yeah, maybe a telephone was a luxury 100 years ago, but everybody has a telephone now. So we've got a smartphone, dating myself here. The technology is getting so much less costly that we might be able to reduce the cost of care by providing points of access mobily or, in the home, that requires a little bit less clinician time, but can deliver the same amount or maybe even more supervision in a care plan than what happens in the traditional format. I don't think the traditional format's that efficient. I'm not an expert in your area, but it just seems if there's ways of documenting my behavior and having instant access to 24/7 AI that can give me some recommendations, but can also send a message to my primary care person that they can act on when needed, maybe provide some decision support, not decision making. Maybe that's a way to reduce the cost and break down barriers to care, have better access to instant care. I mean, that might be a pipe dream. You're the expert in this.
So is this a $5 ad-supported app on my 5G phone, or is this a $500 a year subscription, or is it a $1,000 a year subscription, or a $10,000 a year subscription to get the kinds of services that you're talking about? given the need to maintain the technology, to personalize it, to store it, and so on and so forth?
Well, I mean, for what we're doing, we're looking at a Netflix model for it. It's going to be a subscription based, because if you're doing something ad based, if you're giving somebody something at a low price point because you're selling them something else, then that person's become the product. And that's something that, considering what we'll be dealing with as far as the data is people's actual thoughts and feelings about things, that's not something that you can sell. So we're building our company out on a model of, we haven't decided exactly on the price, but it'll be somewhere between $15 and $25 a month. Now, for certain people, that is very expensive. For other people, that's much more reasonable. But I think the access is going to be a much larger infrastructure issue than just the medical industry by itself, because if you don't have access to broadband, you're missing out on an enormous amount of opportunities across the board now, because so much of the world has gone to a situation where you have to access information, and you can only access that information via the web. I mean, dial-up doesn't really make it exist. So I believe as the infrastructure builds out and catches up, so will the prices come down, because it's going to be an economy of scale.
I totally agree too, right? With the efficiency, economies of scales going up, right, cost goes down. And so this is how we bring that public level of access to the broader scope of people, because the actual work that we needed to get one patient done, right, the cost per patient or the time per patient gets reduced and reduced. Therefore, we are able to do that scaling.
What do you think? I'd love to hear an expert on this. Because I wonder about it too. I mean, are we chasing a dream that's not so feasible economically?
It's the vendor side of this. How much of it is automated, all AI driven? Once you got servers, you don't need a lot of people at the other end. What makes healthcare as expensive is we've got 1 million doctors, we've got 3 million nurses, we've got 750,000 physical therapists, all of whom critical to their work is putting hands on people and taking the time to both hear people and to communicate what is going on. So the issue about the economics of this is the extent to which any of those services get replaced by server-based services, which the economies of scale will drive down.
I think we're going to have to end the forum there. I think our panelists may be willing to stay and answer some questions from individuals. So, this is a public opportunity for people to get involved with UCLA, with these fascinating people who are doing such interesting work. And, Paul Torrens strongly believed that these dialogues is part of what make a great public university what it is. And so if you can, please consider making a gift to support the forum. I also want to say that the final health forum of the year will be April 19th. That is a forum that will honor Jerry Kaminsky and the work that he's done throughout his career. I want to say thank you to the people who shared their time and their information with us tonight. John, David, Skip, and especially to Glenna for putting things together. Thank all of you.